Hello, everybody. Welcome back to Does Science Really Work? The official podcast with the University of Calgary's iGEM team. I'm your host, Khadija Abbas, and I'm very excited for the episode we have lined up today. Today, I have the opportunity to talk with someone inside one of the most challenging and dynamic fields of medicine, neurosurgery. Dr. Brij Karmur is a neurosurgery resident here at the University of Calgary and is also doing a PhD in epidemiology. He offers an insider's view into what it really means to train as a neurosurgeon today, and also where the future of healthcare is headed. We'll dive into his journey into neurosurgery, the role of technology in medicine, and what the next generation of scientists and physicians need to know. Rich, thank you for taking the time to be here today.
Thank you for having me.
Yeah. So your journey, neurosurgery is such a, I don't know, you see it on like dramas and stuff. It sounds like such a hard field. What inspired you to go into this?
Yeah, that's a great question. I mean, it's funny when you, as someone who's not in medicine, when I was in undergrad and before, when you look at shows like Grey's Anatomy, you always have this sort of picture in your head about neurosurgeons, what they do, how they are, and honestly, I want to say that a lot of it's not actually true, as one might expect, and I think it wasn't really any of those sorts of social media or all of these pop culture things that portray neurosurgery that got me into it. It was a bit of a longer thought out process of what exactly do I want to do in medicine. And it was in high school that I was really starting to get interested in and start to know a little bit more about the brain and neurosciences. And so I took a lot of courses, even in high school. In undergrad, I did a bachelor's of life science, and specifically in psychology and neuroscience at McMaster University. And so during that time, I had the privilege of getting mentored by Dr. Sheila Singh, who's a pediatric neurosurgeon, and I was able to see what they do, what kind of personalities they have, and the types of patients that they see. And I was really attracted to the field mainly through having that interaction with neurosurgeons. And at the other end of things, when I was in classes, I used to learn a lot of obviously about neuroscience and neuroanatomy, neurophysiology. All of that got me very interested in understanding how is it that we can actually make a change in someone's health by taking out something that's causing them problems in the brain. So, like a brain tumor, let's say, or something that's making their um, daily living a hassle or making their quality of life deteriorated. So, I think those sorts of things, having those experiences early on, is what got me interested more and more in neurosurgery. And in medical school, obviously, there's a vast variety of options that you can choose from. And I did explore a little bit to see if I liked other aspects of surgical specialties, such as vascular surgery or general surgery. But I was always really interested in the brain and neurosurgery and the intricacies of doing something that would actually change someone's life in a very meaningful and a long lasting way sometimes.
What
So,
inspired you to go from possibly more a scientific route, like
mhm,
I know you're doing a PhD right now, so
yes.
you're kind of hitting both fields, but what inspired you originally to choose medicine over doing a more academia route?
Right.
Yeah.
Yeah, I think a lot of that when you're in undergrad, and I certainly know for myself at least, when I was there, I was really interested in research, and I still am, obviously, as I'm doing a PhD. But I think what I felt missing was that I wasn't able to see it being translated
To the
into
world.
the actual, bedside. And so wanting that aspect of bedside manners or bedside interactions with patients and seeing patients in clinic, seeing patients in the OR, all of those things were obviously missing from academia. And yes, there is a very attractive sort of feeling for research, but I think that was missing for me where I wasn't able to see how exactly is it translated into the bedside. So I think that patient interaction is what really interested in me in medicine.
So seeing that real world impact drew you to more of like the applied field of medicine.
Exactly.
I see. So then your research right now in
Yeah.
epidemiology, do you mind also first explaining what that is?
Yeah,
And
of
then
course.
like,
Of
how does
course.
that tie into
Yeah.
neurosurgery? I don't know. I've
Yes.
seen the two words. I don't come from this
Yes, of
background,
course.
so
It's not the most intuitive. It doesn't it doesn't blend well as easily as some other fields do. But essentially, I'm doing a PhD in epidemiology at U of C, and the PhD is on, if I was to speak broadly, my specific thesis project is trying to understand how I can integrate AI into medical imaging related to neurosurgery. And my project is trying to understand how we can better prognosticate outcomes in meningioma patients, which is meningioma is a type of brain tumor, using AI in MRIs.
Wow. So are you
Mhm.
learning a lot of tech background? Because AI, like,
Yeah. It
wow.
requires a lot of tech background. I don't actually have any. I never actually had any coding experience, and I'm starting to learn that along the way as well. But thankfully, there's a great team that already has expertise in the actual technical background of AI and developing machine learning models, deep learning models, and we're collaborating. Our lab, which is the Project NeuroArm lab, is collaborating with the Medical Image Processing Lab, which is the MIP lab, led by Dr. Niels Forkert. So we're collaborating with different people who are, obviously more, they have more of a technical background and they're much more adept at actually making these models. So I have to learn a little bit so that I know what's going on in these models and I can understand the code that I'm seeing. But thankfully, I haven't had to
Built a model from
build a model
scratch.
from
Yeah.
scratch myself. Hopefully,
Wow.
I can one day.
Hopefully, yeah.
Yes.
That's like a different degree hidden in your degree. Like,
That's correct. I think
yeah.
it's the way the world is going. I think
Mhm.
this is a very, I feel personally, this is a very necessary thing for someone, even in healthcare, even as a clinician, to know about. And if there is someone who has expertise, I think there's definitely a place for that 5, 10, 15 years down the road.
So do you also see that there could be a place for other like robotics also being applied to
Yeah,
into the field of neurosurgery as well? As I
for
heard about
sure.
like stuff like laparoscopy. Is there
Yes.
something similar to that in neurosurgery?
Yeah, so laparoscopy is a very well established field in different parts of surgery. Essentially, it's using a camera, right, to see inside body cavities. So general surgeons use that mostly. And a very different type of instrument, but an endoscope is similar, where we use that in neurosurgery a lot, where for example, there's a specific field of neurosurgery called skull-base surgery where there's tumors that arise in the pituitary gland. And so, if you think about the pituitary where it is in the brain, it's actually almost in the center and in the front, and you can access it through the nose. So, when it started, people used to use the microscope to access it, but with advanced technology, we use the endoscope now. So you can actually put an endoscope in through the nose to look at where the pituitary gland is, look at any tumors that are there, and take those tumors out through that. But if you talk about surgical robotics, that's a very different field in itself because robotics are where you can use a a remote controller to control a robot that's in the OR. So you would be in a different room altogether, controlling something that's inside the operating room, and so you're actually just controlling like you would as a game, right? Your controller's in your hand, and you see on your computer the movement that the robot's making and that you're controlling. So surgical robotics definitely also has a role to play. It's been used in general surgery and urology, in many other places. And the project NeuroArm Lab, which is led by Dr. Garnet Sutherland, which I'm a part of, and that lab is the pioneer in surgical robotics in neurosurgery. And Dr. Sutherland routinely uses the robot to perform many types of brain surgeries. Usually, it's brain tumor removals, and it has its use cases. And not to get into the nitty gritty, but essentially, it's a very very exciting field because at some level, with the integration of AI, I think even surgical robotics will hit a point where it will be much more automated. Where hopefully this may be years down the line, but you would be in a remote location. If you have a robot there, you could be operating that robot from Calgary, right? And I think that that field in itself is has so many exciting potentials that it could see. So surgical robotics is definitely one of those things where it's good to be at least knowledgeable and part of that as well.
I can see how useful that would be because like I don't know too much about neurosurgery, but I heard
Hmm.
like you guys have really steady hands or something. Like it's a very specific and precise skills that you guys have. One
Hmm.
one other question I have is given how your the what's required for neurosurgery is very precise,
Yeah.
do those skills transfer over well in underdeveloped communities? Like
Hmm.
or do you need to be in a well-developed like hospital for
Hmm.
to
Hmm.
apply your skills?
No, I don't think so. I mean, if you look at the world and if you look at any country in the world, you will find that where there's a big, population, if there's a big populace, there's always going to be neurosurgery there. It's a very, at this point, if you think about the number of cases where you have trauma, you have brain trauma, and if you look at traumatic brain injuries, a lot of those I it doesn't have to be a lot, but a fair percentage of them will require surgery at some point. And I think if you look at any country in the world, there will at least be one neurosurgical center where those precise skills are being employed, right? And I think it doesn't have to be within the bounds of a technology-driven OR. You may go to a different country where they don't have a robot, right? They don't have sometimes an MRI in their specific hospital, but they are still able to do the same types of surgery that we do here. But it just may be limited in the way that they can do it, and they may have found other ways, other methods, other technical differences that they're able to employ to actually make those, same types of moves, make those same types of surgeries happen. So it's definitely not something that's just limited to a major urban center.
So it's a very there's still neurosurgery happening all around the world.
Yes, for
I
sure.
see, I see.
Hmm.
So talking more about what your experience has been as a
Hmm.
neurosurgeon,
Yeah.
what is your schedule usually like?
Yeah, really, really good question because um, it's so while we're in training, we have a bit of a different schedule than when we'll graduate and we'll be in practice. So when we're doing neurosurgery residency, we essentially start our day around 5:30 to 6, and we end up so in Calgary, where neurosurgery is only at the Foothills Hospital, we have around I would say 60 to 120 at most people to see every morning. So it's usually in a team of probably 5 to 6 people at most, where we are, fanning the entire hospital and seeing all of these patients where, that's called rounding. And we do that from around, 6 a.m. to 8 a.m. And we're obviously, that's a very short time to see everyone. But because we have a team, we're able to make it happen. And from 8 a.m. to usually around 3 p.m. is when we're operating. We're in the OR and all of the surgeries are going on. And for us in neurosurgery, we do any sort of operation that pertains to the brain or the spinal cord, right? So essentially, we're doing for brain, there's brain tumors that we're taking out, there's aneurysms that we're clipping, there's different types of procedures for certain functional disorders like Parkinson's disease, where we would implant a lead in the brain. And those are some of the more common brain operations. And if there's a trauma, if there's a big blood clot or a hematoma, evacuating those, taking out any sort of infections or abscesses in the brain. And in the spine, if anyone who has arthritis in the spine will have usually what, the pop culture wants names it sciatica. It's a very misused word, but essentially, anyone who has any sort of pain in the legs or any symptoms in the legs are coming from the spine or the spinal cord or the nerves that come outside the spinal cord. And we treat those as well by essentially taking away bone that's compressing certain elements, taking away discs that are compressing certain neural elements. And then if there's fractures in the spine, we treat those as well. If there's tumors in the spine, we treat those. So all of those are parts of, there's many, many more operations that we do, but those are some of the more common ones. So we essentially are in the OR from 8 to 3 ish. And then after that, we spend a couple of hours again to see our patients throughout the day. And usually around, I would say, 5 to 6. is when we leave. However, I would say that there is a caveat where if there's an OR that goes long, there certainly can be. You go into an operation thinking that this will be a 2-hour case, but that's not always necessary. And sometimes a 2-hour case might turn into a 10 or 12-hour case, depending on how things are going, how complex the tumors are, let's say, how complex the anatomy is, and we're trying to safely remove certain pathologies from the brain, and we don't want to rush into things. So often we find ourselves where we're in an OR for 8 to 10 hours, maybe even longer.
Is that where the 30-hour work days come in
Yeah,
for?
so part of that, but the 30-hour work days actually will be there. So what I said about the schedule is for anyone who is just who has a regular day at in a neurosurgery center
13
as
hours
a
is regular.
yeah,
Yeah.
that's very regular
I
from
see.
wherever you go, probably in the world, to be honest. But anyone who's on call, so when we're on call, anyone who needs neurosurgical attention will come through us, and so we're the first person, the first healthcare doctor who actually sees the person for a neurosurgical problem. And when we're on call for 26 hours, and that starts from 6 a.m. until the next day. Our official hours are 8 a.m. to 10 a.m. the next day. But we start a bit early just so that we can be efficient and we can provide the best care for the patients. But usually those 26 hours, if there's still some things left to do, we may hang around for another hour or so. And that may be where, that 30-hour workday comes from. But that's not every day. That's not every day. That's probably so in Alberta, and likewise in the country, anywhere else you go, it's usually 7 shifts that you have to do, call shifts per month. So 7 times you have those 26-hour shifts.
That's actually a lot thinking
Yeah.
about that in a month.
Yeah, it's a
Wow.
lot. I mean, it does take a lot to get used to, but at some point we find that it's just habitual and you get used to it.
So how do you, with all that very long day, how do you first manage the stress, and does it
Mhm.
affect your personal life as well?
Yeah, I mean, we it does affect personal lives. I mean, there are going to be times where we may miss certain events in our life because we're working, right? And I think we all understand that it's a service that others can't offer, and if I'm not there, there's no one to take care of the patients that are going through all of these pretty horrible diseases sometimes, right? And so I think that there is a sense of duty, there's a sense of service that's in all of us and that's for anyone who's in healthcare, anyone who is in medicine, that they feel that when you're going to work, it's not just work, right? Um, but I think everyone has their own way of managing the stress that comes with the job as well. And I think early on, we start to develop these strategies of what is it that I need to do to take my mind away from work a little bit? And I think for every person you ask, it might be a different answer. Personally, for me, I manage stress by, when I just need to get away from work. And when I'm away from work, I'm with my family and friends. And I like playing sports. I like watching movies. And those are two of the hobbies that I engage in to make sure I can just take my mind off things.
Because I
Yeah.
imagine it's just chronic stress, and if you don't do that, then
Yeah, it can be. It can be. But I think, there are people who find their, ways around to make it not really chronic, right? And I think you can certainly develop a lifestyle where you may not be, you're not thinking about work as stress at every moment, right? There are exciting parts of the job. There are more, relaxed part of the job as well. And you're there with co-residents, other staff, other healthcare professionals who you bond with, right? And I think having that work environment also plays a huge role in making sure that that stress doesn't stay chronic.
so you're mentioning how, has there ever been a certain case where you just felt that there's the excitement of it, that your work is so appreciated and valued? Like,
Mhm.
has it, can you like elaborate for
Yeah, of
us a
course.
moment for that?
I think, there's many examples, and probably every day there's at least one example where you can find satisfaction in knowing that you've helped someone, and you've made a difference in their life. And I think, everyone will have so many cases that they go through, but For me, I think the most, it's hard to choose because there's been so many, but I would say there's a time in neurosurgery where there's someone who has a very acute problem where they've deteriorated really rapidly. And that's when someone has what's called hydrocephalus, where there's essentially ventricles that hold CSF, cerebrospinal fluid, in the brain and in the spinal cord. And for some sort of reason, usually a blockage, that space expands and it causes pressure on the rest of the brain, which makes the person become more somnolent. They're drowsy. They're not waking up. It's almost as if they're about to die, which they are. If this goes on for long enough, it's usually fatal. And what we do is a very emergent procedure called an insertion of an EVD, external ventricular drain, where we put a catheter into the brain, into the part where the CSF is being made. And you can ask, honestly, any neurosurgery resident that's a very satisfying procedure to do, because you can see a patient who is almost dying or dead. And once you put that in and you relieve the pressure, usually within minutes, they feel like you're improved so much that they're starting to wake up, they're opening their eyes, they're talking to you, and that usually happened within a span of an hour, right? And so when you do something for someone in such an acute manner, they you can see that change really quickly, and it's a very satisfying feeling to know that you've helped them right in front of your eyes.
Have you ever also had a case where it wasn't necessarily like a it wasn't necessarily a positive result, but on the other end? Or is
Mhm.
neurosurgery a field kind of like
No,
mhm,
you'll see actually a lot of the cases that we do remember is usually the ones that there's some sort of complication with. And neurosurgery is a very difficult field, I feel personally, because the complications that happen in neurosurgery are, they're almost so permanent that it's hard to come back from, right? If you think about just removing a brain tumor, if you're around an area that controls your movement or your speech, and you're trying to take that brain tumor out to make sure that this person has the best chance of living without this brain tumor. However, any sort of movement while you're operating could have any potential damage to those areas. And even if you're not in that space, you could still have a complication where the person wakes up and they're not able to speak, they're not able to move the other half of their body. And so, those are some of the cases that stay with you a lot. And it's a sometimes a very unforgiving specialty. And, I would say that we all struggle with that the most, probably. And that's probably something that takes a toll on us for the entire career. And I
so
could give you examples of surgeons who are so experienced, but they'll still have some of these complications. And it's just a part of the field. It's just a part of the nature of the job, and we just have to understand what we're doing. We always when these kinds of things happen, what we always do is we always debrief and try to understand what we could do differently next time so that we could prevent this sort of thing from happening. But despite that, these things do happen, and we just have to find our own way to cope with those certain complications, and still be there the same way with the same intensity for the next patient, right? Because they deserve our attention just the same.
so how do you cope with that?
Um, it's a good question. I think what helps me is knowing that um, one, I always ask, is there everything that I did, um, with the best intention, right? And secondly, I think as a trainee, you're learning while you're operating, while the surgeon is teaching you how to make these certain moves. And so knowing that I can learn from this and still do something that's better for the next patient, I think helps me at least cope with some of those complications. And sometimes it's hard, like despite telling yourself that certain things aren't in your control and the complications aren't in our control as well. But despite me trying to tell myself that, there's still times where I still remember the first time something happened where there was a complication in my first year, and all of these things stay with me. And it's in a way good that I, you know, reiterate in my head what happened and how I could be better, but also it's bad in a way that it's hard to make them go away, right? And I don't think personally, I don't think that there's any reason to make them go away. It's just that you have to be mindful of what um what happened and how is it that you're going to actually learn from that.
So, how do you personally manage handling being a scientist because you're doing a PhD
Hmm.
and also a doctor? I remember I talked with a philosopher in one of our previous podcasts about
Hmm.
the Hellsman dilemma
Okay.
of trying to, if you're being a good scientist, it would be like the case of you have your control group and then your treatment group.
Right.
And you know that you're giving treatment to one group, but you're purposely withholding treatment from another.
Right.
So, as a scientist,
Hmm.
but also a doctor, a good doctor would give treatment to everyone, while a scientist
Right.
would keep that separation.
Yeah. Yeah.
How do you manage that dilemma?
No, it's a great question. I think so thankfully, I'm not in any position to withhold any treatment. I'm not like the usually it's the principal investigators of these kind of randomized control trials that make those sorts of decisions. But I think there is so I'll give my answer in two parts. One, thankfully, with ethics boards now, there are certain principles that are in place with these sorts of things where if you're running a study like that, you're mandated to, if there is a treatment that you have strong suspicion of working well, then you have to do a crossover where you have to make sure that the control arm still gets that treatment outside of the study period so that they have the best chance at, improving whatever disease that they're trying to improve with that specific treatment. And the other part is, the balance between a physician and a scientist. I think it's actually it's easier for a physician to be a scientist because you see your treatments being given in a very direct way sometimes, right? So um, when let's say, for example, if I'm doing a study that is looking at a new drug for heart disease, just to keep it very, very vague. Um, it doesn't, I'm not ever in a position where I have to see that they're getting this drug and they're improving because I'm participating in a trial in a way that I'm removed, and I can't have my bias going into it. But at the same time, it's easier for me as a physician because I can then the principles that inform the science that I'm doing are actually based on what's happening at the bedside, right? So it's easier for me to be a scientist because I know what questions to ask. I know what patients need, or I know what, as a surgeon, what I would need for a specific patient population, right? So it's in a way easier as a physician because that informs all of these research questions that you're asking as a scientist. Sometimes, and not always, because scientists these days, especially anyone who's in healthcare, they're very well versed with the nitty-gritty of the healthcare environment, that they don't need to be an actual healthcare professional to know everything about that disease. But there is still a little bit of an edge that you get being someone who actually provides direct care for a patient, and then taking that back into your lab to run experiments or to develop questions that will answer those problems. So it'll actually benefit in a way to be a physician, to do science. And then, I think that with the Helmsman dilemma you're talking about, I think as research ethics have evolved, it's becoming easier that we don't have to face such a big dilemma anymore because the ethics board actually won't approve some of these questions that you ask if they feel that you're doing disservice to one arm, the control arm, let's say.
So you would say that first off, the ethic boards takes the burden off your
Yes,
shoulders,
exactly.
and then also that as a physician, you're able to see the real world
Yeah,
problems firsthand. So that
exactly.
helps with future innovations in this
For
field.
sure.
Have you seen from your
Yeah.
experience, one case that really helped with your research that going forward, that
Hmm.
creating something that could a new innovation
Yep.
in this field, like a personal
Yeah,
case?
certainly. I mean, I can talk about my research because
Mhm.
I know it the most, and I don't know how, let's say, other innovations would have happened in the same way. But I can tell you about my research, why I'm doing what I'm doing. So, if you, as I said, I'm doing my main problem that I'm focusing on is meningioma, which is a type of brain tumor, and this is the most common brain tumor that happens in people, and there's a different grade that's assigned to it depending on how aggressively that tumor grows within the brain. And when we're looking, let's say someone comes into the surgeon's office saying that I have a headache, feel like I feel nauseous, and I'm vomiting for the last week. So they would get a CT scan or an MRI, and then that CT or MRI will pick up that they have a brain tumor, that they have a meningioma. Now, knowing just that they have that isn't enough to know how aggressively that tumor is behaving, right? So if I take a look at a CT, if I take a look at an MRI, I don't know right away if this is a really aggressive tumor or this is not so aggressive. And so part of what I want to do is develop a machine learning algorithm that actually picks up on certain cues that we can't with our eyes to know that this is a grade 1, grade 2, or a grade 3 tumor, let's say. So that's where I see that happening. Where I've been in ORs where we're taking out a meningioma from a patient's brain, but while we're doing the operation, we're there and we're thinking, well, we don't know. This is usually 80% of these are usually benign, meaning that they don't come back as aggressively. They don't recur as often. And so, while we're taking this out, is it part of the 80% or is it part of the 20% that's a really aggressive tumor that's going to come back in 6 months? And so we should be treating it a little bit more aggressively or not, right? So that specifically will inform how should I be removing these tumors moving forward, based on my preoperative understanding of this tumor being grade 1, grade 2, or grade 3.
Yeah.
So your background really helps with that because you have such a experience with that innovations and your research going forward becomes you're able to
Exactly.
narrow down.
Exactly.
I
Yeah.
see. So it seems like just hearing this, it seems very you do a lot of hard work. Like like
Yeah.
what support system did you have to enter such a field where you're not only you're having the background to do neurosurgery, but also go into research and help innovate in that area? What support system did you
Hmm,
have,
hmm.
like growing up, like something to for future scientists or future or like children? Like
Yes.
what what do they need to be
Yeah.
like
For
support system wise?
Yeah, that's a good question. I think, as I said, I'm privileged that I had the opportunities that I did, to get into neurosurgery, to get into research. And I hope that that in itself can be an impetus for a lot of people to get into neurosurgery as well. But I think at the core of it, it really just does take interest and passion. I do think that if you're passionate about a certain topic, a certain field, a certain area, it doesn't have to be in science, it could be in anything. I think at some point, um, that starts the process. And with that, I think you need to be supported around you, with, an environment in your school, let's say, or you can create that environment in university where you're engaging in activities that'll help you understand why you have that interest and develop that interest further, right? And I think um, a lot of those opportunities are something that if you do seek out in school, if you do seek that out in university, or in college, I think that does impact how that shapes your understanding, how that shapes your drive for that particular field. And I think, when you talk about support systems, I think that's usually what's necessary. And I think, anyone who is in, let's say, a center like University of Calgary, I think will be privileged enough to have some of those, aspects of support systems that are readily available for them, right? And I do recognize that there's certain privileges that we all have that maybe different for each of us. And having those opportunities aren't always the same. But if there is an interest, I think you can start the process. And with that, there are many systems that will readily support anyone who does have that interest to move along with that, with that passion.
So it'd be necessary. So in regards to technological innovations, what's the next 10 years look like in neurosurgery? What new innovations are you expecting to see?
I think neurosurgery is a very new field in not just surgery itself, but also in medicine. And because it's a new field, I think there's just almost every day there's something new that's coming out in neurosurgery. And it all uses technology because as surgeons, that's our most widely used tool for our work. And so there's new and new technologies that are coming out. I'll give you a couple of examples. One, as I said before about functional neurosurgery, we put in implants in the brain to affect change in someone who has Parkinson's disease, let's say. So similarly, you might have heard about Neuralink, and they're implanting chips, and that's helping people with who have movement disorders. So I think that's one area where there's so much change that's happening. There's so much innovation with how powerful these technologies are in reading signals from your brain and actually affecting the changes so that you can, let's say if someone who wasn't able to communicate, not able to speak, to give them the voice that they had. Neuralink recently announced that they're going to try and do something with vision, right? So how big would it be if someone who doesn't have vision because of something wrong with their eyes, but their brain still processes things? So to translate what the brain processes to vision for someone who's blind. These are all examples of innovation that are, I think in the next 10 years will take us to some place. And there's other fields in neurosurgery as well. So anything that we do, we are trying more and more to make it more minimally invasive, because it's just, the outcomes for patients we've shown through research are better for patients. So one example is for someone who has cerebrovascular disease in the form of an aneurysm in their brain, or someone who has an arteriovenous malformation, which is the entanglement of arteries and veins that they're born with. A lot of these things are something that can be treated minimally invasive now with just a puncture in the femoral artery or the radial artery, where you put a catheter in and through those arteries, and you go up into the vasculature of the brain, and you can trap an aneurysm, or you can put in a liquid material like what's called onyx into an AVM to make it smaller. So in neurovascular surgery, that's something that we're seeing more and more now in spine as well. So usually everyone thinks of spine as a very big sort of incision where you get a big cut down your spine, down your back, and then you have all these screws and rods that are put in. But we're starting to now be able to do that through smaller and smaller cuts, that we don't have to open a huge area of the body. So that's one of the technological innovations as well. And then specifically in AI, I think this is where, not just in these technological advances, but in anything that uses technology in neurosurgery, we are finding that we're probably going to be able to integrate AI into it. And once we're able to integrate AI, it will become easier to do what we're doing. So it may not be something that replaces a task that a surgeon does, but it will be something that helps us do something more efficiently, let's say. So I think, those are just some of those advances that I think we'll see moving forward.
So there's in innovations, there's fields such as the students can look at that would be AI. There's also the Neuralink trying to affect actually how the human brain perceives things. And there's also stuff in this field specifically, such as minimally invasive surgery, that's very on the surgeon side, very technical with that. But there's also other fields such that people can look into that they can apply their research to, because neurosurgery is like a very new thing.
Yes, exactly. And I think this is, all of these things start with research, right? And we need to have studies that are done to help us understand, is it actually working for patients, right? It's good to do minimally invasive surgery, but is it something that's actually improving patient outcomes? Are there less people who have infections moving forward? Are there people who are able to, have better stays in hospital or shorter hospital stays? Those are the outcomes that we want to know that are improving what we're doing, right? And I don't think we're going to do something just for the sake of doing it. I think research is an integral component of all of these innovations in helping us understand, is what we're doing actually working, and should we be continuing in these particular areas of innovation or not?
And you
Mhm.
also mentioned Neuralink.
Yeah.
That's when I first found out Neuralink, I was kind of, it sounds so scary to be honest,
Yeah.
like a chip
Yeah.
in your brain.
Yes.
But it sounds like also such an application of new biology, of using
Yes.
synthetic biology.
Yep.
What are your thoughts as a neurosurgeon?
Yeah. So a couple of things. I think obviously it's a very famous company now, Neuralink, and the work that they're doing is they're showing that it's actually working in patients, and what they're doing is also something that has to undergo research, right? It's not something that will just be approved without any sort of research process. So they're also doing the same sort of rigorous research and understanding. Is their implant or is their product actually doing something for patients? And I think the big thing to understand about what they're doing, I think, is in pop culture, everyone has this understanding that a chip in the brain means that someone will be able to read my mind or someone will know what I'm thinking.
Or someone
And I think
controls you.
exactly. And I think those are very, very far off sort of advances in brain implants. It's really, really hard to um, affect that kind of a change with a chip in the brain. I think where if you look at the Neuralink and anyone else, there's many other labs actually in the world who are using the same sort of technology in their research. And there's no process in that implant that actually uses technology to understand someone's thoughts or their behavior. All they're trying to do is read signals that translate into motion, let's say, right? So for someone who has a neuromuscular disorder or an injury to their brain, a part of their brain that makes them unable to move, what the implant is doing is just reading signals from their specific areas where the movement is controlled, and then they transform it through an interface that actually helps them move a robotic arm, let's say. So that's actually what's going on, and so this idea of this chip is going to enter my brain and read my thoughts, that's not really true. And I think we're far away from actually developing technology that can help us understand how all of these brain signals convert into thought, right? So um, that's one thing. And then the other thing is is this chip going to influence what I do, right? So first of all, most of these chips, when they're implanted, they're in an area that does control movement or that does control speech, let's say. But um, we're doing the opposite with the chips. We're trying to go from the brain to the outside world instead of the outside world into the brain to affect change. The only time we do that is when we have implants for Parkinson's disease, where all we do is there's a not a radio frequency, but an electrical change that is made into the implant that will turn a specific circuit of the brain on or off, or it will affect that specific circuit only. And that's actually what will affect their movement, right? And so if you see someone who has Parkinson's disease, when they go from the on to off state of their implant, it's not really affecting anything at the structural level. It's just changing the electrical impulses. And I think that we're far off from that chip making us or that chip controlling our behavior. And I think that a lot of the things that we see in pop culture and media about that is misinformed.
Mm-hmm.
Hmm.
But I mean, when I first heard about it, I also did think about that. I was like, how am I sure that they're not doing
Yeah,
something else?
of
But
course.
like as you were explaining, it does the brain has so many things going on that I guess even doing that one specific thing must be like getting
Mhm.
that signal and completing that one circuit is already enough for life chip.
Exactly. And I think, we're like that. It's, if you think about it, it's actually a really simple task that the chip is doing. And being able to control us or reading our minds is a much more complex task
I see.
that it would have to do. And I don't think we're quite there yet.
So it's more like acting as a switch rather than a whole chip, even though it's like a chip.
Yeah. Yeah. It's so when we put it in, it's actually a lead, it's an implant. Of that's like if you think about a wire that's about 5 centimeters long that goes into your brain. But again, it's not really there to do anything else. Just change the electrical signals of the brain.
Oh, okay. I didn't know that. I thought it was an actual
So
like
that
chip.
those are two different things. Yeah.
I see.
So the chip itself is the Neuralink chip,
Oh.
or that's a different type of implant.
Mhm.
Versus this implant is as a lead. That's for Parkinson's or movement disorders.
Oh, okay.
Yeah,
Okay. So those are two different things.
exactly.
One's the actual Neuralink and the other one's the thing that completes a circuit.
Yes.
I see.
Mhm.
Okay. Okay. Thank you for explaining.
Of course. Yeah.
Also, I've also heard of another innovation of using synthetic biology in this field called
Right.
regenerative
Yes.
medicine.
Yes.
Do you mind also elaborating what that
Yeah.
is?
Sorry. So, yeah, regenerative medicine is also really interesting, and I think in neurosurgery, at least, we're not quite there in using it in a very sort of um, everyday practice. The regenerative medicine, with when I think of that, I think of stem cells and using the power of stem cells because they're pluripotent cells, so they could turn into any sort of cell you want. And that's the theory of using regenerative medicine and using stem cells to affect change. So I think the idea of doing that in patients who have an injury that has made the part of that brain or spinal cord pretty much dead permanently. I think that's where the research in that field is going on right now. Not so much with the brain, but with the spine. So spinal cord injury is essentially, one of the most devastating injuries that can happen to the spine and even the brain. If you think about it, where you can't move the parts of your body lower than where the spinal cord is injured. And if someone who has what we call a high cervical, where it's higher up in the neck, where they have the injury, then usually anything lower down means it's your arms, it's your legs, and sometimes it's even your muscles that control breathing. So all of those things are affected, and that part of the spinal cord is dead. So you can't have motion in your arms or legs after that. And a big area of research is using stem cells in that specific area where it's injured to know, can we actually regenerate some of those neurons, some of those astrocytes or microglia around that area to regenerate some of the function that
So
you've lost.
the neurons don't regenerate by themselves?
That's correct. So, if you think about the liver, if it gets injured, there's some sort of regenerative potential to it. Skin, there's a lot of regenerative potential, but anything in the so neurons specifically will not have in the CNS, so central nervous system, they don't have any regenerative potential.
And the central nervous system is the brain and the spine.
And brain and spinal cord.
I see.
So the nerves that come out, those nerves are part of the peripheral nervous system, and there is some regenerative potential to it. And it's nothing like the skin or the liver. They don't grow as fast, but those nerves can grow back. Those axons can grow back.
I see.
Mhm.
So the new innovations in this field is trying to, for the central nervous system, trying to see if there can be a way to regenerate those neurons.
Exactly. Yeah.
That would be really impactful too. Like if someone can't walk anymore.
Yeah. And that's exactly where a very big topic of research is in spinal cord injury.
We talked a lot about all the different pathways for innovation. There's AI,
Mhm.
there's Neuralink, there's stem cell therapy, and if you had a student who was interested in doing an innovation in the neuro field, what's one pressing problem that you would give to them to like solve that?
Yeah. That's a great question. I think it's a difficult one to answer because
There's so many
there's so
answers.
many.
Yeah.
There's so many areas. But I think one that's a little bit closer to my heart, I think is in brain tumors. And I would say not so much with the innovation that we've talked about, but with different kinds of innovation. I'll talk about that in a second. But the specific problems in neuro-oncology, if you think about, and most of the people that you'll ask, they'll probably agree that glioblastoma is a major neuro-oncological issue where essentially it's anyone who has this disease, this tumor. Glioblastoma is a type of tumor. It's the most aggressive primary brain cancer. So we're not talking about cancers that start elsewhere in the body and metastasize to the brain, not that, but a cancer that starts in the brain and it spreads everywhere. And it spreads so rapidly that the usual survival for anyone who has that is around 14 to 18 months. It could be longer for someone who has a very specific type of the tumor with specific genetic markers, but for those who have, what we call an IDH wild type, is where they have the more aggressive type where their survival is usually 14 to 18 months. And that's a very, that's a very well, or not, I wouldn't say well researched, but a lot of people are trying to understand the biology of this tumor and trying to develop therapies for it. And a lot of the newer therapies that are coming out in that field are with immunological work and also with virology as well. So using different types of scientific and specifically biological mechanisms to affect change more than the technological or technology side of things. So I would say that's something that if someone personally came and asked me, that's what I would say is you should do research in GBMs because this is a very lethal tumor.
And it's something also people can do without having that tech background and more of a bio background.
Exactly. Yeah. Molecular biology
Molecular.
molecular biology and biochemistry are the fields that in GBM research is used the most.
Oh, wow.
Mhm.
So we talked about all the new innovations that are possible for students who work on in synthetic biology. And we did talk about Neuralink and clearing misconceptions about that.
Yeah.
But do you think there are still other ethical concerns about these new innovations
Mhm.
that we should be a little cautious of?
Yeah, that's a good question. I think it's a bit difficult because we haven't really seen the true potential of these kinds of technologies yet, and how far they can go, even with AI, right? I think there's a lot to consider about the ethics of all of these technologies. I think for the most part, if you think about, let's say, minimally invasive surgery or what else? Surgical robotics, right? There's not that much that goes into it ethically. Maybe something with robots, but if you think about AI, if you think about these implants, um, once we see like the potential that they will have in everyday practice of neurosurgery, we may be able to better judge that, okay, you know what, this is something that this technology can do, but we're not going to go that far yet. So, for example, if you think about AI and let's say even just what I'm doing with my project, if we have a certain technology that helps us understand that this tumor that we're going to operate on is grade 1, grade 2, or grade 3, if I use that and I do a surgery with it, and if I get a complication, how much role did the AI model play in me getting that complication? And how much of what I do could be a direct result of AI use? So that's a very big area of ethics in medicine in general as AI is integrated into the field more. And if you think about even surgical robotics, I said, let's say I have a robot that I'm controlling, right? If the robot malfunctions, even though I'm using the robot, is it the robot that's to be blamed for a specific, maneuver that it did, or is it the controller? Um, and where do we draw that line, right? So I think there's a lot of things in what we do in neurosurgery every day that could be affected by this, but it's hard to know until we actually do them on a daily basis. And it comes into our practice that much more readily to understand what are the actual ethical implications of this. But a big thing is to make sure that we're thinking about it before we start to implement these things in practice, right? And I think that one big revolution in AI that's happening is actually understanding the ethics and the ethical applications of AI in medicine. So there's definitely a lot of considerations with any technology that comes out. But I think these are specific areas where I think we're going to be a little bit more vigilant in understanding, are we actually using this ethically or not?
So putting the new innovations to use and having the people who are creating the innovations think out how they can affect the different fields. Because that's something I didn't even
Yep.
think about, the whole, if like robotic arm, if it malfunctions, who's to blame? Like
Yeah.
there's gonna be a significant outcome, which
Yes,
is harm to the
exactly.
patient. But that is such a case I'd never even considered
Yeah,
before.
and I think those are important questions to ask for sure.
Mhm, mhm. So we're talking about your experience throughout. Your journey was it's a very long, gruesome journey, but also very purposeful. And I'm sure you built so many skills in regards to resilience and
Mhm.
just how to manage all of that. What advice would you give to a student who's also pursuing a hard field? Not necessarily neurosurgery, but more a field that also requires a lot of time and then a lot of effort, like maybe like entrepreneurship,
Right.
or even if they're doing neurosurgery.
Right.
What's a skill that you think that you gain most from your journey?
Hmm. Um, it's tough to decide because I
You can give
think
me a list. It's okay.
no, I think at any point, and I've always strongly believed this because neurosurgery is not the only thing that's difficult out there, and I think there's a lot of misunderstanding that there's this common saying that it's not brain surgery or it's not rocket science, right? And I don't think that those are the only things that are hard out there, and I think there's definitely a skill set that you need to have to enter these fields that demand a lot from you. Um, but if I'm going back to the reason why I do this every day, it just ends up with what I talked about earlier. It's passion. I think that if you truly find meaning in what you're doing, then it doesn't become a strenuous task. It doesn't become a difficult task. Or it could be difficult, but you're looking forward to that difficulty, or you're looking forward to that challenge. And I think it always comes down to, do you find meaning in what you do? Personally, I believe that in whatever field you go into, right? There's a very common question that we talk about in medicine when you're applying for medical school. If you're asked, why do you want to become a doctor? And a common answer to that is, because I want to help people, right? And which is true. Most people will go into medicine because they want to help people, but so does someone who builds bridges as an engineer. So does someone who makes a software for a major bank, right? So is someone who essentially delivers the mail, right? Everyone is doing what they're doing because they're trying to help people, right? And I don't think there's specifically anything that about that actually differentiates doctors or other healthcare professionals. I think it's about how you find meaning in helping people, right? And in how you want to do that, right? So I think that's essentially what I come back to, is that if I have the passion, it's going to be easier for me to find meaning in what I do on a day to day basis. And that's why I think that any sort of stress that comes with the job, any sort of difficulty or any challenge, any points where you're required to be resilient, it becomes easier to do those when you think to yourself about what you're doing and how it's impactful and the meaning that you find in doing that work.
I think it's a really
Mhm.
good answer. Thank you.
Mhm.
I actually really do agree with that. That when you're doing work, finding your why and why you're doing it, when it
Yep.
gets tough, which it will inevitably,
Mhm.
when you have that why, you can get through those tough
Of
periods so
course.
much easier.
Yeah.
So thank you. So I have a rapid list of fun questions for you.
Sure. Okay.
So if you weren't in neurosurgery,
Yes.
what would you be doing right now?
I would want to be a civil engineer.
A civil engineer.
Yeah, I've
Huh.
always found it fascinating looking at the architecture of certain buildings and just how it all comes together. I think it just intrigues me a lot that we as people are able to just build something that grand and that intricate sometimes. So yeah,
I actually agree with that. When I see planes flying in the sky, I'm like, how are they doing that? Like,
exactly.
I know how,
Yeah.
but like it's still
Yep.
so shocking,
For sure.
sometimes. But next question.
Mhm.
Can you describe your learning philosophy in 3 words?
Ooh,
I want to
learning
learn from
philosophy.
this. You're a you're a nurse. I want to get your
Yeah.
tips.
In 3 words, I think it would be difficult, but
Maybe I'll give you 5.
sure, that's fine.
Okay.
But I think it's to stay passionate, to be inquisitive, and to be humble. And what I mean by that is to never think that you know it all.
Hmm,
Mhm.
I see. What is your ultimate study hack?
I don't know if I have one, even after all these years of studying.
I've heard interesting ones, such as like grinding coffee beans.
Interesting.
Mhm.
No, I haven't had that. Honestly, no, I don't think I have a study hack, to be honest with you. I'm still like looking out for things now. I'll be looking like anytime someone sends me a video about like, oh, this is how I study now. I always find it intriguing. I'm always trying different things. But I think change in environment is my ultimate study hack, is that if I have like a full day of things to do, if I just like every hour I change where I am or how I'm doing it or the certain position I'm in, I think that helps me.
I see.
Mhm.
So, throughout your long educational journey, how much sleep did you average?
Um, definitely, I'm averaging way more now than I was when I was when I'm in actually in residency and working clinically. Um, I would say on average, I like 5 to 6 hours.
Wow.
Actually, not average, but I would say yeah, 5 to 6. It's never like 4 hours all the ways, but yeah, sometimes it's 4 hours, sometimes it's 7 hours, but yeah,
Wow.
it's in that range.
Wow. I guess it makes sense though. Like I heard as you grow older, you need less sleep.
That's true.
So
I
maybe
hope I'm not that old yet, though.
Yeah. Do you have any closing remarks you'd like to give everyone? Like your
um,
words of wisdom you'd like to share?
I don't know if I have any words of wisdom. I don't think I'm wise enough for that. But no, I think it was. Thanks again for the opportunity
Thank you
to
for
come and
being on
chat.
here.
Yeah, of course. Happy to be here, and I think I don't think there's anything that I can say more than what I've said already. But I would just say that a lot of people are always very afraid of having a difficult life, and that's why sometimes in medicine, I find that when I'm talking to medical students, they don't want to do neurosurgery because they see how we live and the type of life that we have, and it's very busy, and we do sometimes not sometimes, but often we don't get the same amount of sleep that other doctors get. But I would still say that still give it a try and be inquisitive about neurology, neurosurgery, understanding the brain, the neurosciences from as early as you can, because I think this is the most fascinating field out there, and I would recommend it to anyone who comes to me and says that what should I do in medicine, let's say. And I think that despite us having maybe a more challenging life, it's just as fruitful and it's just as satisfactory. And I think that if you really dig deep, you will find a meaning or your meaning in doing this.
Thank you so much for your
Of
time
course.
today.
Thanks.
Thank you.